The New Zealand Health Department position is this.
My name is Robin, Dr. Robin Haseman Welsh. I'm the Chief Dental Officer for the Ministry of Health. I am a registered dentist, a wife and a mum. I drink fluoridated water. The most recent national study, the 2009 New Zealand Oral Health Survey, showed that on average, New Zealand children had 40% less tooth decay when they were living in fluoridated areas compared to non-fluoridated areas.
Now, Robin is a very charming and professional dental health colleague who I find most approachable in discussions. She's highly competent at implementing the DHB policy. I'm concerned, however, that the benefits are overstated and are not based on objective advice. The problem is that the 2009 New Zealand Oral Health Survey was not designed as a scientific study into oral health status of people by fluoridation status, as it says there, and did not control for confounding factors by its own admission. To use this in making public health policy is therefore very inappropriate. The 40% figure quoted comes from this table, in the 2009 New Zealand Oral Health Survey. It is the relative difference when you compare the mean DMFT of children aged 2 to 17 by fluoridation status of their current residents. Note also that the relative difference over all age groups is much less, falling to about 20%. This evidence supports observed cross-sectional age group comparisons may be reflecting delayed decay experience rather than prevention. According to the 2009 oral health figures, children living in unfluoridated areas have an average of 2.4 teeth with decay experience in the age group up to 17 years old, compared to an average 1.5. Now, there are 28 teeth present, and that's why my graph looks a bit funny, because I've shown the relative amount of teeth in the mouth. So the absolute difference of 0.9 of a tooth out of 28, or about 3% by age 17. Overall, over all the ages surveyed, ages 2 to 74 years old, the data of the Oral Health Survey shows an average lifetime difference of 2.5 teeth DMFT by fluoridation status. The other finding of the New Zealand Oral Health Survey, however, shows that there has been no improvement in lifetime decay experience following introduction of water fluoridation, the way that I'm reading it, with the 65 to 74-year-olds in 2009 having exactly the same number of decayed, missing and filled teeth as the age group had in 1988 and in 1976 even. This data again suggests that the effect of fluoridation is simply to delay tooth decay as opposed to preventing it. The data I presented indicate that if you account for potential confounding factors of research bias and retarded tooth eruption in fluoridated areas, as identified in the York report, community water fluoridation is probably of no clinically significant benefit to decay reduction in developed countries. So is it possible that decay reduction previously attributed to community water fluoridation was actually the result of other community and lifestyle factors, and that a myth has been knowingly or unknowingly perpetuated by enthusiastic dental researchers who have succumbed to bias in representing the reliability of their research to public health authorities? Is endorsement of the beneficial effects of community water fluoridation a case of the Emperor's New Clothes syndrome? We now agree that the theory held for 50 years that swallowing fluoride during tooth development was barking up the wrong total tree. There is now no argument. Oh, geez, sorry, I forgot the slide, guys. There is now no argument that the action of fluoride is a surface contact effect, and the fluoride incorporated into teeth during development does not make them more resistant to plaque acids. The only reason left to justify swallowing fluoride is the hope that it might raise salivary concentrations to a level that can slow down an early cavity. The whole argument rests on whether the levels attained are high enough. The research indicates they are not, and this was conceded by the leading promoter of fluoridation, the CDC, in 1999, who stated that this concentration of fluoride is not likely to affect carcinogenic activity. It would appear that while drinking fluoridated water was considered a better than nothing hit and hope method 50 years ago, with the widespread availability in countries such as Australia and New Zealand of fluoridated toothpaste from the 1980s and increased fluoride in the food chain, dental materials, drugs, its questionable usefulness is redundant, and responsible health authorities and politicians, faced with mounting evidence of health risks and dwindling evidence of efficacy, have only one option in the public interest, and that is to stop putting artificial fluoride in the water supply. It would appear that the European Union Committee of Science, Health, Environmental Research, who report no obvious advantage appears in favour of water fluoridation compared with topical prevention. The effect of continued systemic exposure is questionable. This suggests that water fluoridation plays a relatively minor role in the improvement of dental health. Last one. Should we be making such important decisions about health based on propaganda? I ask you to give your own consideration to this, and I thank you for your time today.